Welcome to yet another episode of ET Health World's webinar. The topic for today's discussion is the surge in private hospitals making India's healthcare unaffordable. In this session, we bring together a panel of distinguished experts to unravel this complex issue. Let me take a moment to introduce them. We have Mr. C.K. Mishra, former Union Secretary, Ministry of Health and Family Welfare, former Union Secretary for Environment, Forest and Climate Change, Government of India. Thanks a lot, Mr. Mishra, for joining. Next, Dr. K. Madan Gopal, Advisor, Public Health Administration, National Health System Resource Center. Thanks a lot, Dr. Madan Gopal, for joining in. We have next Dr. Suchin Bajaj, Founder Director, Ujala Cygnus Hospital. Thanks a lot, Dr. Bajaj, for joining in. Next, we have Dr. Prem Pavur, PhD, Managing Director, Head of India Ventures, 8 Roads. Thanks a lot, Dr. Pavur, for joining in. And with me, I have Mr. Vikas Dandekar, Editor of ET Health World and ET Pharma, who will be moderating this session with me. I am Pratibha Raju, Senior Assistant Editor. So we have just 60 minutes and we have got a very, big topic to talk about. So let's just start the discussion. So my first question is, I will direct it to first to Mr. Mishra. Sir, there is a glaring disparity in the healthcare costs under PMJ. The government sets fixed rates for procedures, while private hospitals charge significantly higher. For example, the dialysis under PMJ costs rupees 1,500, while in private hospitals it is between 2,500 to 5,000. When you go for a coronary angioplasty or a diagnostic angiogram, it is somewhere around 40,600 under PMJ, but it ranges from 66,000 to 2,15,000 in private hospitals. And also a single chamber pacemaker implantation is 24,500 under PMJ, and it goes up to 2 lakh in private hospitals. So I wanted to know, these stark differences make critical treatments unaffordable for many middle income families. Why is private healthcare becoming increasingly expensive, and what solutions can be bridge this cost gap? Should there be a stronger regulatory interventions or innovative insurance model to ensure affordability, given India's per capita income and evolving healthcare ecosystem?
Thank you, Pratibha. This question is something that many people want to know. Frankly, everybody tries to find his own answer to this question. Let us look at a couple of facts first. Yes, the Indian healthcare provisioning in the private sector is rather expensive, and the current state of big hospitals providing services is unaffordable to the common man. These are facts. At the second level, it is unfair to compare PMJY with private provisioning. You know, it's a very interesting thing that many of the private hospitals tell me that they use their normal patient load to actually cross-subsidize what they do in PMJY or CGHS treatment. Now, unless this disparity is reduced, reaching expensive treatment to the common man and reducing out of pocket is going to be extremely difficult. So what do we need to do? If you ask me, two critical things have not happened, three in fact, have not happened in the healthcare industry. First, the investment that government was supposed to put in healthcare provisioning has not kept pace with the requirement. Therefore, you are forcing people to increase out of pocket and go to these hospitals. The ideal scenario, because that's the way the health system in India has been built, a 4-tier health system, was precisely for getting people who cannot afford that healthcare to be able to avail of that in the government system. Unfortunately, a lot of movement has happened, but it's still suboptimal. Second thing is that insurance models in India have only partly worked. When I say partly worked, what I mean is that they have not been able to really satisfy the need of the people And even the insurance cost has not been such that those not supported by government can also go for insurance. So in universal insurance is a big crisis. So what we need to do is A, increase our investment. B, we need to get more and more private players in the field of hospitals. You have to create a competition for competitive prices to come up. Three, and this is a valid point that the private hospitals keep making, that the cost of operation of a hospital of a big nature is very high. I think it is time that government policies supported creation of such hospitals with some kind of a government relaxation and support so that the ROI is better, and then you can sit and insist that the cost will not be very high for the common man. So affordable treatment in India today is all still a distant thing. We have created access everywhere, but affordability is still a big issue. I'm not even talking about quality. That's a that's an issue we need to discuss separately altogether. But I think if you really want to bridge this gap between what the insurance rates, government supported insurance rates are, and what the hospitals are, A, we need to have more such provisioning places, and B, we need to support private sector to actually come up and reduce prices. I mean, including diagnostics and radiology, pathology, everything. Otherwise, the 2.5% that we spoke of in the health policy will continue to remain a government burden. It was not supposed to be a government burden. It's not the government's business alone to provide healthcare. So this private investment must come in at some stage later. If you, I mean, if we have an appropriate question, I'd actually like to talk about the trend in investment today. But we'll do that later. For the time being, let's stop here. Thank
Yeah,
you.
that was a warm-up question. So I would go to Dr. Prem now because Mr. Mishra has spoken about the investments. Dr. Prem, your views. Quickly, we have a lot of questions. Yeah.
Hello, Kate. Thank you for having me on the panel. I think lots of more experienced people than me. So looking forward to hearing their views. And I think going after Mr. Mishra is always a tall ask. Uh, I think in general, if I look at the historical trend, close to 70% of hospital capex in the country has generally been financed by the private sector. The government has financed about 30%. It has been the historical trend, in fact. Uh, if anything, now we see two dichotomies. You see the government uh, basically making a call that they would rather be like countries like the US, where they would primarily play the role of a payer, through schemes like Ayushman Bharat, etc., rather than playing the role of both the provider and the payer. And if anything, it has expanded the sector greatly over the past 4 or 5 years. I think both in terms of the number of chains that have emerged, and number two, in terms of just investments into the healthcare sector, which have gone up. It's the only sector in the country where private equity investments have jumped 2x from pre-COVID levels. I think most other sectors have seen a tapering in investment. I think Mr. Mishra makes a great point in that if you look at it historically, the private sector, and as these larger chains more or less moved up the curve in terms of size of facilities, in terms of the capabilities they provided, I think the prices have gone up. Uh, but I think schemes like Ayushman Bharat have played a big role in terms of expanding the market too. And I think the case in point I always provide is uh, the chain that Dr. Suchin has co-founded many years ago called Ujala Cygnus. which has taken, I would say, which has nicely leveraged the scheme to be able to provide more affordable care to a lot of people. So now I think, we see a clear segmentation of the market. You see the large chains continuing to expand both in the metros as well as the tier ones. We are seeing a new set of players that are coming up in the smaller cities. These are upgrades from nursing homes. These are players that, are being set up to provide more affordable care, mass value care. And then we are also seeing a next set of players that are now being built specifically for schemes like Ayushman Bharat. How do you manage high throughput? How do you manage, serving the patients with high quality, but, keeping cost in mind? How do you make sure that, you manage outcomes, which I'm sure Dr. Suchin can speak about much better than I can, right? And so we are seeing, as I call it, hospitals that are being designed and fit for purpose for Ayushman Bharat. So uh, I think, look, therefore, when you take that holistic care, I think you're seeing the emergence of different strokes for different categories of players emerging in the country, and it will play out over the next 3 4 years.
Thanks a lot, Dr. Babur. I would go to Dr. Suchin now. Dr. Suchin, your views. Maybe you were not that much happy about the PMJ, scheme. You can talk about that as well. Yeah.
No, no. I see. Our focus, as Dr. Prem said, has always been to, treat each and every person who walks into our door. So, what we have been trying to do over the last 12, 13 years that we have been working is to try and flip the traditional private healthcare model, which has been traditionally a high cost, low volume model, into a low cost, high volume model. We've been trying to flip it, and schemes like PMJ, etc., always help in that. It's a different matter altogether that I'm not a big fan of fee for service in healthcare, because that truly misaligns the incentives of the doctors and the patients. Because if it's a fee for service, then as a doctor, my incentive is okay, you have a heart attack, you come to me, I'll treat you, I'll put in a stent, and I'll earn the money and you'll be fine. But the patient's incentive is really to not have that heart attack, really, right? So in a fee for service model, who's working hard on making sure that the patient doesn't have the heart attack? We are not really paying GPs or primary healthcare providers or preventive healthcare providers, dietitians, exercise people on, making sure that people are healthy and do not go and have that heart attack. And the true cost of the disease, we always fail to assess completely. So we may say that private healthcare is making it more expensive, but what is the true cost of the disease? Is it really the 3,000 rupees per dialysis that is the true cost of the disease? Is it 25,000 rupees for amputating a gangrenous foot due to diabetes? Is that true cost of the disease? The true cost is not that, right? The true cost is much, much higher if you do not have a foot, if you are in kidney failure due to diabetes. The true cost of the disease is much higher. You have lost earnings in the future because you can't go to work. You pull your children out of school to send them to work. So many future generations are destroyed because you could not control that. So as CK Mishra sir also said, the system was very well intentioned when we had this 4-tier system in place. The government did it with all the good intentions, but having failed to follow through on keeping it adequately equipped, keeping it well established, making sure that we keep pace with the increasing population. Most of the medical college additions, etc., have been done in the last 5 years. Except for that, if you see right from Independence Days to last 5 years, the number of medical colleges, primary health centers, etc., have not really kept pace with the increasing population. So we need to do a lot of things to, the healthcare is a very comprehensive and complicated subject. So just saying that privatization is increasing healthcare cost, I think, is a bit simplistic, according to me.
Okay. So I'll bring in Dr. Madan Gopal here. Sir, your views, please.
Okay, thank you for the question. I think the heart of the problem is very simple, but it is very uncomfortable too. As our incomes are rising, the healthcares are also rising. But the pace between the rising incomes and the healthcare cost needs to be kept in. But if you look at the need for the hospital care, that is also rising. And you take the MOSPI data and other data. I would not be quoting any sources, but rough estimate says that we require around 42 lakh beds in the country to cater to all the inpatient requirements as of today. But currently, we are having around 19 lakhs beds, of which 11 lakhs are coming from the private sector. Rest of the things are from the government sector. And if you add to the PM Abhim and the other program which are in pipeline, you will add another 2 lakh plus beds. They are not inadequate. They are not adequate. But if you look at the need for this bed, that's why the private sector is going, because they are catering to the need. And then when I was working with Niti Aayog, and at that time we focused on that, there was a task which was assigned to us saying that if all the patients of PMJ, that is around 70 crore people, now it is 70 crore now roughly, of this 3% they are subject to hospitalization. Do we have the adequate number of beds to cater to the needs? The answer is no. That's why when we were started talking to the private sector for bringing in investment into tier 2 and tier 3 cities, then we came across very stark realities. Why the cost is very high in the private sector. One is the private sector brings in the technology to keep abreast in the competition so that they are having a competitive edge over the others. If they don't bring in the technology, they will lose clientage. And the cost of acquisition, when we were talking to the venture capitalists and others who are bringing in the investments into tier 2, tier cities, they told that the cost of acquisition, because it's a very uncomfortable tool, but the cost of acquisition of patient is roughly around 30%. And that is all loaded on the patient, and that is adding to the cost. That's one thing. Second thing is there are input cost escalations also. If you talk about this, they pay good salary, they pay things also, and they have to bring the best talent to them. Besides that, to attract the people, the NABH and the JCI accreditations also, that's all cost intensive. Besides that, when we were discussing with the hospitals, it was pointed out that for the industries, they get uh, rebate on the electricity charges. One of the major concern was the cost of the land, which consumes around 25% of the hospitals, and that too unencumbered land, because they have requested that they can procure the land, but they want an unencumbered land. But all this cost, where it will land in the healthcare cost. The other is the electricity cost, which is very high in most of them, because high-end equipment requires a lot of electricity, and they are paying at a commercial rate. Though industry status has been given to the healthcare industry in 2017 budget speech, but still it is yet to be implemented in letter and spirit. That's another thing. Because the other example which we have seen, the hospital, they try to subsidize the poor patient with the other people as a part of their commitments. So you see that cross subsidization also add to the cost, and that also shoots up this. And the last another thing is that's a very debated topic. That's regulating, how to regulate this thing. I've been talking to many of the providers and say that why don't you have a self-regulation mechanism before the government chips in? How to say that if this kind of procedure happens in a particular NHS hospital, what could be the cost differentials in that hospital? If the associations come forward, at least they will start self-regulating it before the government chips in. These are the three things. I think 4 or 5 things which are contributing to the rising cost of the private healthcare in this. But nevertheless, we have to always keep in mind that the incomes are also rising. The cost of cost of healthcare is also rising. The health inflation, it is around 14% now. That means PMJ has at least changed the behavior, health-seeking behavior of the patients. They are now seeking more healthcare, and as a result, they are spending more on the health expenditure. So you have to see that though the out-of-pocket expenses one way would be shown that to reduce, the government is also expending, the expenditure also coming down, but the household expenditure on health is increasing because the health-seeking behavior has changed. So that means how you balance all these things, that's a very, very complex issue. I think with the course of discussion, at least we can see how much insights we can get to crack this issue.
Yes, it's a complex issue. As I could see, the first question itself had good elaborate answers, and I'm trying to pull in Mr. Vikas. Sir, over to you. Have questions, pointed questions to the panelists.
Right. Yeah. Thank you so much, Pratibha, and thanks everyone for sharing their thoughts. So I'm trying to make sense of what probably we will be seeing in the next couple of years. So, according to the data that Pratibha put together a couple of days ago, 22,000 beds are going to be added in the next 3 to 5 years. That's triple the number that we have seen between FY19 and 24. At the same time, just yesterday's news was about an update where we heard in the parliament 609 private hospitals opted out of the Ayushman Bharat scheme. Now, uh, from what we gather from the investor community is the next level of investments will be coming from tier two, tier three, and such other centers. So, how do we actually bring all of these, combinations together so that affordability is a challenge. There is a deficit there. Dr. Bajaj mentioned that accessibility has been given there, but affordability part is something that remains a big question. So, Dr. Pawur, you would like to throw some light on that, because if the fresh investments are happening in the private sector and the whole uh, channel is moving towards the smaller cities, and yet there is a reimbursement challenge, how do we, all these investments will also need to be seen from the ROI point of view, right?
No, absolutely, Vikas. I think we've seen an unprecedented increase in the venture capital and private equity deployment in the Indian healthcare sector over the past 24 months. And as we think about it, it's largely come, as Dr. Madan Gopal, I think, articulated it better. I think it's come from an increase in affordability. Uh, Number two, in my mind, it's come from an increase in awareness. I think the mobile phone has significantly bridged the information asymmetry between the patient and the doctor for the first time. I think every patient now goes, thinking that, he's fully educated on the condition when he goes visits the doctor, and often, wants more than one opinion, often wants to also shop, across different health systems and hospitals for prices to make sure that they're getting the best quality at the most reasonable cost, etc. So you've got awareness having gone up, and access will go up, given all of the investments in the sector. Instead of clubbing it at the in a lump sum, because I would say you've got to stratify it a bit. So you've got the larger investments, the few $100 million investments that are going into the large established hospital chains. I think the expansion for them is going to come from both horizontal expansion of their current facilities, right? Everyone wants to build out a Cleveland Clinic type of model, in their flagship centers, or it's going to come, going to the next set of cities, right? And these are not rocket science. Everyone is going to more or less the same set of cities after the metros. But you also then see the smaller ticket investments, right, which are sub 100 million or so, that are going into the more emerging chains, right? And I would say that Ujala Cygnus was the recipient of a successful investment last year. But we've also seen uh, hospital systems in the smaller towns, in Uttar Pradesh and Gujarat, etc., being the recipient of these. And as you delve into those, these are the systems that are going not to the tier one, but they're going to the tier two and the tier three towns, right? And then you've got another set of investments at the smaller ticket size that are going to now think about building facilities to cater to the increased payer coverage that the government has provided through schemes like Ayushman Bharat. So if I look at, if I look at the hospitals that have come to us asking for investments over the past couple of years, almost everyone has 50% or so revenue share from government schemes, and every one of them has talked about ramping that up. So while you might talk about the number of hospitals that want to delist from Ayushman Bharat, that will always be a constant churn. There are enough and more hospitals that want to enlist when it comes to Ayushman Bharat, and everyone is talking about a government strategy as well as a private payer strategy in their system. So I would say, look, I think the net effect is that investments will go up. I think gone are the days also, Vikas, where 10 years ago you could set up a hospital in a tier 1 city, and just given that you are the only hospital, you would see patients come in, revenues would go up, EBITDA would come nicely, you would get to 60-70% occupancy, and you had a very profitable system. Those days are gone. I think just with the extent of investment that you've seen now in the last 2-3 years, you will see an enhanced amount of competition between hospital chains and also individual hospitals. That is bound to drive down, and everyone, as Dr. Madan Gopal said, is going to compete for the same patient, right? So while demand is going up, the number of hospitals is also going up, and that will drive prices down. It will sort of put a pressure on quality and how patients perceive the quality of the hospital being. So I think you're going to see a change in the hospital landscape in the next 2-3 years, as all of this money now gets utilized to build more hospitals and expand the number of beds.
That's a very interesting course correction, if I can say it like that. I mean, the way things have moved, it's become unaffordable. I was actually talking to a colleague. I mean, it's not about the low income strata anymore. It's even for the people who are fairly, in a good income bracket, even they are not able to afford. So, with that backdrop, I'd like to indulge Mr. C.K. Mishra. Sir, about the Clinical Establishment Act, the whole thing was about displaying the rate boards. Some of the states that actually adopted it, even there, the situation is not really helping. Um, how do you describe this situation? Because, that was seen as something that can probably curb runaway prices and bring some, because quality healthcare cannot be so high that it just becomes unaffordable.
Thank you, Vikas. I mean, before I come to the Clinical Establishment Act, which I will, just give me a minute on another point that's being discussed here. It's an excellent conversation to have that health seeking behavior is changing, awareness is changing, hospitals are growing, investment in hospitals are growing. Therefore, more and more patients are coming. So, this entire conversation is around patient care is equal to hospital. It is this conversation that makes me extremely uncomfortable. What policy for a populous state like India do you want to have? Do you want to have a sick care policy or sickness prevention policy? It's a lopsided investment that is happening today. And as long as this lopsided investment happens, I don't think the cost of treatment is likely to come down. You need to look at it at the base. The other option is you need more Sachin Bajajas to come in and create that low cost hospital functioning model. So this is, a really, really serious thing. And just one more point. Private equity is a very welcome thing in terms of investment. Makes me a little wary because private equity is centered at quick return on investment, not on healthcare. What this country needs is healthcare. So let us keep these distinctions in mind. Now, coming to your question of Clinical Establishment Act, it's been one struggle where Government of India has not succeeded. Very few states have adopted it, and those who have adopted it have done nothing. The joke in the health ministry is that you can't fight the doctors. They're just too powerful in any state. But the fact is also lies elsewhere. You don't want to disturb a system where some kind of provisioning has happened which you as government are unable to provide. So States which are not interfering, this is the thinking. That if I disturb the current equilibrium in the system that is going, and I don't have the wherewithals to step into, kind of compensate for that, where does the person go? In fact, 2017 or 18, one of those years, we invited all the states and said, see, this is a model clinical establishment act that we have. Do what you want with it, but get your own act and implement it. Nobody has done it. I think 2 or 3 states got their own act, which is a photocopy of the Central Act. So we've not got anywhere with the Clinical Establishment Act. This brings me to another critical point. Do we really want to regulate hospitals as if we are regulating ration shops? Is that the desire? Can we, for a moment, at least presume that the hospital structure is managed by much better people who can perhaps regulate themselves? Honestly, and Dr. Bajaj and Dr. Pavud may agree or disagree. We've not seen that kind of a support coming from the hospitals themselves. Forget displaying rates. Even in the conversation, the rate is not made clear to the patient. The patient, till his discharge, doesn't know what his actual bill is going to be. So I am of the view that while I fully support these hospitals which have come up because they're serving a larger population than government is able to, I think time has come, you need to be transparent. And let me also sound a warning bell here. If you remain non-transparent for a long time, you will invite intervention. And then I think you have no ground to climb.
Yes, exactly. I think that's where a couple of price curbs actually happened a couple of years ago, against which US policymakers have not been really very happy. Dr. Bajaj, time for you to come in here. Either you do a massive expansion pan India, or we'll need to have some replicating models that you have followed.
Oh, I thank you for your vote of confidence, especially when C.K. Mishra sir says something. It is like his words are worth gold to us all the time, and we hang on to everything he says. So, if he has, said something for us, those words are really precious. So, thank you so much, sir. What are the what are the things that are holding back more private investments into these smaller towns and more doctors trying and going to work in these smaller towns? Make no mistake, it is a very stressful job, attracting good quality doctors, good quality nurses, getting the best technology in place, and then serving towns where the cost per treatment, the average revenue per patient, or the average revenue per occupied bed per day may be less than 15 to 20% of what the big city hospitals may be charging. And healthcare is a very outcome oriented business, right? You can't have bad outcomes at all. I mean, you can't compromise on quality at all. You have to provide the highest quality. All your hospitals have to be NABH accredited. You have to have outcomes which are at least at par with the big city hospitals, if not better, to attract more patients. So if you're trying to do that at low costs, I think the government needs to step in to incentivize these hospitals a lot more than the laissez-faire attitude that is currently at place. We've had some issues where, unfortunately, government now says that we will pay the big city hospitals a higher rate than the smaller town hospitals. With this myth keeps continuing that operating hospitals in a smaller town is cheaper to do. It is clearly not, and please, talk to me whenever somebody thinks like that it's cheaper to run a hospital in a small town. So the government needs to step in more. They need to incentivize doctors, especially more, to go and settle in small towns. And the hospitals, I think the hospitals, as C.K. Mishra sir said, we really need to incentivize the good players in this and disincentivize the bad actors very, very quickly. So we need to create more transparency. We need to make sure that quality parameters are in place. We need to make sure that hospitals, publicize their outcomes and their rates very transparently. Once we have those actors in place, we need to really incentivize them. So get their reimbursements quickly in time. Make sure that you unnecessarily don't harass them on minor things. Make sure that the payments that are due are cleared up very very quickly. So once these things come in as a policy and are seen to be executed publicly by the government may do some mistakes, some errors on the side of paying access to these players rather than making an error on the other side. Then I am sure many more doctors and many more private players will be very happy to go and set up these hospitals in these small towns where the actual need is, and operate on these schemes and the government incentive plans that are in place already. I think we will see a lot more happening in that sector if the government really is interested in doing that.
Pratibha, you can take the next set of questions.
Yeah, Dr. Sachin, you had spoken about the schemes, right? So there's 54% increase in CGHS spending, particularly the growing reliance on private hospitals. It raises concerns about the neglect of preventive care. So CGHS was originally designed as a general practitioner-led or a neighborhood-based service focused on preventive and promotive care, right? So how do we justify this shift towards referral agencies for private hospitals without adequate oversight on the necessity and cost effectiveness of these referrals? Because there's a lot of spending which has been done by the government side on CGHS. That is what has been told by in the Lok Sabha and the budget session, I suppose. So I would like to go to you first, and then I'll go to the rest of the panelists. Yeah.
I think again it establishes what I've been saying for a long time, that we really are not working on the root cause of healthcare. We are just driving sick care more and more, and with the fee for service structure in place and the government pushing more on becoming a payer rather than a provider and doing a fee for service model which is insurance based, these things will keep creeping up. Who is incentivizing the doctors to make sure there are no heart attacks, to make sure that primary care is in place? GPs are a breed that is fast vanishing. Everybody wants to be a super specialist. How many MBBS graduates do we have now who are willing to practice as a GP? They want to do their MDs, then their DMs. They want to become a super specialist, play with the latest toys, because that is where the entire money is. We really need to learn from NHS on how they have really incentivized their GPs and nurse practitioners. And in some cases, I've seen the GPs and nurse practitioners earn much, much more than the specialists and the super specialists in the NHS system. And this is how we've seen their hospitalization rates for simple things like COPD. I remember reading a data that for COPD, the hospitalization rate in the year 2000 was almost 15%. So 15% of patients used to get admitted every year into a hospital. That has decreased to less than 2% in the last 25 years because the incentive that the GPs and the nurse practitioners get, the preventive care is so much more in vogue right now. So who is incentivizing that? CGHS, to be really blunt about it, I think has degenerated into a referral system. I don't think there is anything more than that. They're just referring patients to the private hospitals, which is an unfortunate thing because it was set up, as you said correctly, as a preventive care, setting up clinics in the neighborhoods, making sure that you get good preventive and primary care in time. But who is incentivizing those GPs to make sure that they do that is something that the entire system has to answer for.
Okay, adding one more question to it, I'm going to Mr. Mishra. Sir, with CGHS reimbursements to private hospitals has risen by almost 300% from 2019 to 2020. To 2023 to 2024 is what I have got the data from. So what measures need to be considered to ensure more effective control over cost while maintaining quality healthcare for beneficiaries? It's ultimately for the patients, right?
First and foremost, this overemphasis on CGHS is misplaced. You're talking about a very small population of central government employees, and they cannot be the mark of whether India is developing in the health sector or not. Having said that, yes, the payouts have increased. Two reasons. A, as Sachin said, the referrals have increased. Therefore, the cost of treatment has gone up. B, that 300%, my guess is, also hides a lot of previous dues payment taking in subsequent years. I mean, CGH is a brilliant system, terrible paymasters. Having said that, I mean, government's intent should be to make where were these CGHS patients supposed to go? They were primarily supposed to go to government hospitals. Why is it that they're not going there? Because neither the patient nor the referring doctor is confident that he'll be taken care of. It's a very sad thing. And that is why these costs are going up. But the primary root, as Sachin pointed out, is the entire debate for the last 20 years or so is treatment, treatment, treatment. I mean, I dare say, I would not dare to say it openly. I feel it's time to scrap the 4-stage system and try a GP system and give everyone a fixed population to take care of. I would love to see a few pilots happen. My hunch is that will be the success for India. Thanks.
Thanks a lot, sir. Dr. Madan Gopal, you want to add some input, sir, on that?
There's one interesting aspect which you have mentioned. But when the CGHS was started, what was the age of that population? Now, you have to see the working conditions of the central government employees as well. They work late hours. They start on time and work till late hours. And as a result, they forget about their health and wellness. As a result, what happened? Whatever dispensaries are there, so many of the people are having comorbid. That we have to see that how we take care of that comorbid conditions. As things happen and they have some episodes, they frequent some private institution. They come back to the dispensaries and try to see that how to refer, how to handle that thing. That kind of perplexity is there in the CGHS thing. Second thing is, many of the CGHS people, they are now having an insurance also, private insurance, because they are contributing something, but they are not getting the kind of services which is envisaged. We have to see that a revamp can also happen. But the main important thing is it's the central government health employees. All the employees are central government, and there was an effort made when PMJ was launched, how to bring them into the PMJ fold or some other fold. But report was there and it was stalled. It could not happen to reduce the cost and everything. But see that how we can make it a most cost-effective thing. They are paying it. Why can't an annual annual health examination plan can be built into the CGHS thing, which though as a part of the employment they undergo employment test, the annual health examination, but all the family members, everybody, they can, because that's worth investing, and that can reduce the cost of the cost of the treatment, which is now increasing in the CGHS also. In the ESIS also, we have explored this thing. We told that, do we have a health checkup or a data for the primary screening of the population, for the insured population? So that also we have been able to put some this pilot in the ESIS hospital. Let's see the results of that pilot. If they are screening it, whether it has reducing the cost of the referrals and other things. That also efforts are going on in that model. But in CGHS, I'm not sure that this is being experimented or not.
Pratibha,
Yes, sir.
I think you need to have a debate publicly on why is it that more and more people, in this case, the government servants, are getting sick, and why do they need referral? If you can resolve this, the rest of the issues fall in place.
Sure, sure, sir. So I have one on the out-of-pocket expenditure question. So with out-of-pocket expenditure declining from 64.2% in financial year 2014 to 48.2% in financial year 2019, and government health expenditures rising marginally from 1.2% to 1.3% of GDP. in the same period. As a public health system done enough to reduce the financial burden on citizens, or is it still disproportionately reliant on the private players? We are always reliant on private players. When this balance will happen? Over to you, sir.
Pratima, it's not the case, because if you look at the efforts made by the government, because when the NHA was started, I think during such tenure or around that tenure it started. We started having our own NHA and the reports were published. At that time, it was found that the out-of-pocket expenses, which used to be around 70%, uh, few of the areas were identified. As a result, the free drugs diagnostic initiative was started, because the drugs and diagnostics was consuming 40% of the expenditure. Besides that, apart from the free drugs and diagnostic initiative, we had the Jan Aushadhi also, the generic medicine, and now the number of the outlets are also increasing. More than 10,000 outlets are there. So these are two initiatives for addressing that issue of reducing the out-of-pocket expenses due to this drugs and diagnostics. Apart from that, in the PM Aving is the largest infrastructure uh, mission which the health has seen over the last many years. 70,000 crore is there, and as you have mentioned that 20,000, but we are envisaging that it will add to around 2 lakh 2 lakh beds to the center. Besides that, when the footfalls in the government sector is also increasing, but you remember that we are dealing with 1.4 billion population. Whatever number of health infrastructure and institutions which the government is building and creating, that has immediately been taken up and immediately overcrowding and other things would be there. We are already trying to see that how many number of institutions can be added. That's one thing which is happening. Besides that, other thing which we are trying to address the issue of out-of-pocket expenses is providing the transportation and the emergency care, because these are the other areas where a lot of expenses happen. We have seen that how the emergency medical, this national ambulance services have been catering. We are supporting around 30,000 ambulances now. And across the 108 and other ambulances which you see under NHM, they are all supported under the government. It is aimed at uh, reducing the travel time, as well as reducing the expenses on the patient. Besides that, free of cost treatment is there. Other important thing which the government has done is the rollout of the PMJ program. It talks about massive scale. With this kind of scale, you will have certain problems, operational issues, and other things. One of the things when it was launched, one of the caveat which was there when I was involved in that, I've sent a caveat from Niti Aayog saying that the delayed payment should not be tolerated. There should be zero tolerance for the delayed payments. But due to some various operational reasons or various other things, now the delayed payment is one of the cause where many institutions are walking out of the thing. That means it can be addressed, the operational issue which can, but the felt need of such kind of services is there. And if you look at all the umbrella of the services with the government is doing, it's all aimed at reduction in out-of-pocket expenses. The recent thing, recent NHA account, they say that it has come down to less than 40%. But the converse is also happening. The health inflation cost is rising. The expenditure on household expenditure on health seeking is also increasing. Yet, as the government is increasing its expenditure, the health expenditure is also increasing. We have to see that how the net result would be. So that's a situation which is evolving. Let's wait and see how it affects the out-of-pocket expense.
We have a lot of questions from the audiences as well. We would also like to take it because we have few minutes. But before that, I would want to hand it over back to Vikas sir. You have one or two pointed questions for the panelists. Quickly, we can take it up and then we can go to the audience questions.
Yeah, more or less, we are in time to conclude. But before that, a dichotomy that I think is happening here is again something that is aligned with one of the questions, that the expectations whenever there is an investment is to have the returns within a stipulated time, and then we are actually bound by the affordability needs. Of course, there will be a correction in charges, as Dr. Pavur also mentioned, but they kind of run in opposite directions. Any thoughts on that, Dr. Pavur? I mean, do you think the investment period probably needs to be much longer so that good healthcare can actually reach the strata that has not actually seen it?
They can invest in Dr. Suchin's chain to get the 100x returns.
You did that.
But We did that and we were privileged. In fact, that's the only hospital system that we have partnered with.
Yeah.
But look, I think that A, it's great that we are all able to talk about, what can India now evolve to? I think until 2019, in the absence of Ayushman Bharat, we didn't even have more or less universal health coverage. Right now that we've seen 5, 6 years of it, right? The question is, what is the next wave of development for the sector? And until we didn't have that, right, the primary care chains operating on their own, right, were not making a compelling enough investment case for investors to invest money in and feel like there was a likelihood that the unit economics would work and the investment would multiply. Because look, realistically, we also do it with a profit perspective in mind. But I think that has changed, and I think Mr. Mishra, I think, touched upon a lot of this. While I do come from the community, I think an interesting statistic that is aligned with what you mentioned, Mr. Mishra, is, and I assume you must have seen this, but a few months ago, the US published a report which said that the health outcomes for patients in hospitals that were private equity funded were significantly worse than from hospitals that were not private equity funded, right? Because private equity comes in and drives operational efficiencies. And the question is, does that happen? Does that happen, to the disadvantage of patients? But I think as these systems are established, right, which is you're all moving towards, how do you keep the patient out of the hospital, right? We had an investment in the US called Iora Health, which did exactly what Mr. Mishra is proposing, which it basically took a small community outside of Atlanta in Georgia and said, I will holistically manage the care of these patients. So everyone paid them a fee. And then through a network of largely GPs, some IPD escalation, they managed patient health holistically. It was a combination of technology, very strong primary care, prevention, so that only the cases that really demanded the escalation, were basically taken to the hospital. They saw a significant improvement in outcomes. Uh, I think similarly, as systems move here, where more or less you begin to establish systems like a Kaiser Permanente, or maybe slightly closed systems where you have the primary care physician, you have the secondary care, you have escalation in tertiary care, it's linked by technology. I think those types of systems then become much more interesting, even for investors to think about, because they provide they basically think about it as a holistic model. They provide, the the patient flow into primary care. They provide the triaging to the hospital system. They also sort of encompass a hospital system in that whole loop. That I think becomes much more interesting. So I think my sense is that how people view primary care and different specialties, you are now beginning to see, for example, investments happening in outpatient chemotherapy settings. You're seeing other settings, uh, also see a lot of interest. I think that wheel has just begun to move, and therefore I continue to believe India is at a very exciting point in terms of evolution. I think the US is just about a few years ago began for the first time talking about value-based care. We're only 5, 6 years through Ayushman Bharat, right? We are already talking about value-based care. How do we make sure that we drive patient outcomes first and then think about the system? But these are all changes that we can make now that the foundation is in place.
Yeah, absolutely. Yeah, in fact, that will be good not to move in the direction that US has gone. I think, yeah, time for some questions, Pratibha.
Yeah, we have a few questions like from the audience, where one question is about their from Dr. Sapna. She says she loved the idea of primary healthcare, but a lot of VC and PE funded startups trying to work on PHC have failed, as again they expect money from 10x or 100x. healthcare is a different ball game. People need to believe in you to get those returns, which happens with time. How to work on this is the question.
I think the investment that is being made in healthcare, I mean, the first point is to Dr. Sapna that if an investment fails and a hospital collapses, it's far worse for India than an expensive treatment in that hospital. Let's get that. I think investors need to look at it slightly differently and in a long-term perspective. And perhaps that investment needs to be supported by some policy initiatives of government, which makes it easier for them to invest and easier for them to expect the returns. Primary healthcare, there's been hardly any investment. And that is why I keep repeating again and again that we are only treating the sick. That's where all the investment is going.
There are a lot of questions. I don't think we'll be able to take up everything. There's one more question on investment again. The Miss Kavita Gandhi, I think she's a CA. Investment in healthcare by PE is in trend. However, I feel the valuation is going quite considering potentials of the company. And she's given a very elaborate question. Will it? She's just asking, can PE get exit after 3 to 5 years with similar multiple? Which are the points that I'm missing in valuation process that investors are considering? Dr. Prem, you want to answer that?
Yeah, it's one of the reasons that we haven't invested in the hospital sector in the last 3 years, while we've seen so much investment going into the sector, because we do feel that the valuations have gone up, and everyone has been chasing investments in the healthcare system. I think she makes a fair point in that this is a sector that requires patience. Like I always say, my learnings from 17 years of doing this is that in the healthcare industry, which is both life sciences and healthcare, things always take longer than you think they will, and they're always more expensive than you budget for. And so a 3 to 5 year tenure is short for any investment in the healthcare sector to go through its ups and downs and to mature. We were partners with Cygnus for close to 9 years. Uh, the So I think there will be some expectation resetting in terms of the hold period that I think some of these investors who have just entered the sector will realize. Uh, I think that there will also be some. I think the reality, though, is that the demand for healthcare has also gone up, right? Meaning that's just the reality. And some of that demand will get absorbed by, this increased investment, and some of it might not. And so there will be a normalization of valuations, right? But the country is also growing and things like that. So in the next 5 6 years, do these multiples stay where they are? Do they go up further? Do they come down because there is overcapacity? Who knows? But I think that there will be some expectation setting at the minimum on the hold period that you need for these investments to mature.
Thanks a lot, Dr. Prem. Vikas, over to you.
Right. So, I mean, we still are left with a bunch of questions, but time is really running out, and we'll have to wrap it up here. But as a good discussion always concludes, a couple of very good points made by our panel experts. What comes as the gist is, the need for an increase in healthcare budget. Sickness to wellness, that is also something that is very critical. Failure of Clinical Establishment Act. Thanks, Mr. Mishra, for making that very bold statement. We've been waiting for that to happen. Dr. Prem Pavur made a very interesting point and a very heartening one about course correction in the way patients are charged, because everyone is going to take the same patient. Increase in the allocation is what Dr. Bajaj was mentioning. And probably, there will be an uniformity. And of course, the investment climate probably will become more conducive. So I think these are the key takeaways. These discussions don't, end in 1 hour. But thank you so much for all these great, points that you all have made and gave us your time. Thanks so much, listeners, for being there and making it richer with your questions. we'll keep trying to get them back on the same platform again and again as we see new issues unfolding. So thank you so much again, and thanks Pratibha for doing it all, the groundwork and getting all the speakers on board. Thank you again. Thank you so much.
Thanks
Thanks very
again from
much.
my side to all the speakers. I'm not going to leave you all. I'll keep bothering you all with such webinars and for our in-house events. And please keep writing also, and please suggest. You're the experts. If you have anything which needs to be told to the patients, please suggest us as well. And thanks to again all the listeners as well. Thanks, Vikasa, for your time. Thank you so much.